Once again, I want to say hello to everyone that's joining us on Facebook, YouTube, and Zoom. We know that you are loading in. If you'll wait to the top of the hour, we will get started. I think we're there.
Okay, I guess I'm going to get started. Welcome everyone to the Skin Cancer Symposium. We are all at Duke University. My name is Georgia Beasley. I'm one of the surgical oncologists, and I'm joined, this is our itinerary. I'm joined today by several of my colleagues. We have planned a 30-minute question and answer session at the end of all the presentations. Viewers joining us on Zoom can submit their questions by placing them in the Q&A tab located at the bottom of the screens. Facebook Live viewers should put their questions into the comment sections, and then they will be transferred to Zoom. For many years, AIM at Melanoma has been approached by the public about providing skin cancer education information for other non-melanoma skin cancers. So in January of this year, they created the AIM at Skin Cancer Foundation, an accompanying website. Ann Garst-Taylor is the Director of Community Engagement for AIM at Melanoma and will be detailing the various resources available through their new foundation website at the end. So we're very excited to be hosting this for you all and hope that it's very educational. So I'm going to introduce in order of the presentations. First, Dr. Mosafar is a medical oncologist and the clinical director of the Head and Neck Medical Oncology Program at Duke. He is a clinical and translational investigator with a focus on the development of new therapies for head and neck, thyroid, and salivary gland cancers. The second speaker will be Dr. Meenal Kadarpal, who's a dermatologist who specializes in the treatment of patients with skin cancer. She has run multiple clinical trials in transplant patients and also has an interest in the AI application and teledermatology. And then finally, Dr. Salama is a medical oncologist who specializes in the treatment of patients with skin cancer and leads the melanoma program in the Duke Cancer Institute. She treats, including Merkel cell and melanoma. She's led a number of clinical trials advancing care for these patients. So I'm going to end my part of this and get started with our first speaker.
Thank you, Dr. Beasley. I really want to thank the entire team at the AIM at Melanoma program for giving me this opportunity to be here and participate in the symposium. And I hope that I'm able to increase awareness and educate all the people who have joined the program today about some of the latest advances in skin cancer. So let me share my slide first, and then we will see. So again, thank you, Dr. Beasley, for introducing me. I'm an associate professor here at Duke. My primary area of focus is head and neck squamous cell carcinomas, and I also am currently developing the cutaneous squamous cell carcinoma program at Duke, where I'm seeing a lot of these patients that are being sent to us. Again, I thank you for this opportunity. Here are my disclosures. I'm only going to talk about things that have been approved by the FDA with just a brief mention of some of the clinical trials. Again, whenever we talk about any cancer, we have to always start with the epidemiology. And this is a very simple way of presenting the incidence of skin cancers. We see that the most common type of skin cancer is basal cell, while squamous cell carcinoma and related cancers comprise about 17 to 20% of all the skin cancers that are diagnosed. And as you can see in the graph on the right side, is that both basal cell and squamous cell, which are the two most common, their incidence, due to their unique nature of the pathogenesis, keeps increasing with time, both in men and women. And what we see is that the incidence keeps on increasing almost up to the age of 85 to 90 years before it really starts to fall. And even then, the fall is a slow one. So it's very high likelihood that people, especially people who have fair skin and live in sunny areas, are going to experience or be diagnosed with at least one cutaneous squamous cell in their lifetime. So what that tells us is that as we're going to see lots and lots of these skin cancer, especially the basal cell and squamous cell, and more of these patients are going to be seen in an older age and population. We have to review some of the risk factors associated. Now, risk factors can be divided for squamous cell, can be divided into three parts: environmental, internal, and others. In the environmental, which is the most common, is the sun exposure, especially the UV radiation part of the sun. So people who live in places like Florida or Southern California who are exposed to sun and go out on the beach a lot are going to be at a higher risk of getting these squamous cells. And then we have things like poor therapy. Tanning beds are a big source of squamous cell carcinomas. And then we have exposure to certain drugs and chemicals like arsenic, polycyclic aromatic hydrocarbons, and ionizing radiation. A second group of population that I see very frequently are these patients who have some kind of an immune suppression, either due to inherent deficiencies in the immune system. And then Duke being a solid organ transplant center, we have a lot of these organ transplant recipients who develop very aggressive skin cancers. This is very, very hard to treat, but recently we have had quite a few advances in this field, and I'm going to discuss that later in the talk. And then last, we have patients who have some sort of genetic alterations like xeroderma pigmentosum is a big cause of cutaneous squamous cell carcinoma. And then we also have infections like HPV, especially the 6, 11, 16, and 18, which are implicated in the development of cutaneous SCC. Just a quick pathology review. It passes through the stage of damage through UVR and then transitions to a pre-malignant cell stage, followed by carcinoma in situ, and then invasive cutaneous SCC. Now, among the latest advances that we see in cutaneous squamous cell these days is the increased identification and recognition of these mutations and markers in the genetic alteration, which are leading to increased incidences of these cutaneous SCCs. One of the main implications also is that some of these mutations are amenable to targeting by drugs, and so it's important to look for these to offer better treatment options for our patients. This lists a lot of the stuff that we see, but what we see commonly here is that TP53, CDKN2A, these are tumor suppressor genes, and we see a lot of cutaneous SCCs who have these mutations, which are the driver mutations for them. Then we also find things like the KN, and the CARD11. These are more specifically associated with exposure to the UV rays. And then one of the main things also to look at is the EGFR. EGFR is dysregulated in a lot of cutaneous SCCs, and that also provides us with a target to treat these cancers. Whenever we are talking about squamous cell, it's also important to look at some of the risk factors which help us to identify which patients are going to do better, who are going to do worse. And we have a whole list of stuff that we are going to look at, which helps us to prognosticate these patients, which also helps us to determine how best to treat them and prevent relapses. So if you see here, poorly differentiated forms which have lost their primary differentiation are going to be much more aggressive, with a 3 times larger, higher incidence of local recurrence, twice incidence of metastasis. Then depth of invasion of the primary tumor is a big factor in how patients are going to do. Any depth more than 2 millimeters is a 10 times more likelihood of local recurrence and 10 or 11 times more likelihood of metastatic disease. Similarly, we have things like PNI and LVI, which are very high risk factors for progression of disease, and especially local recurrence, and LVI for metastatic disease. Sometimes the location of the tumor itself makes it high risk, especially in the temple, ear, and the lip areas. And as expected, larger tumors are going to do worse, and tumors arising from scars are also going to be much more aggressive in terms of how they spread and metastasize to the body. This gives us a very broad idea. The cutaneous squamous cell treatment is a multidisciplinary approach. There is always going to be involvement of the dermatology team, the surgical oncologist, radiation, and the medical oncologist. So it's a very complex decision-making process. And at Duke, we have a multidisciplinary tumor board where tough cases or complex cases are reviewed, and input from all the possible team members which are involved in the care of these patients are used. And that is where a lot of these decisions are made to proceed with either surgery or radiation or do neoadjuvant immunotherapy, which is one of the newer stuff and things that have emerged in cutaneous squamous cell. So because I am a medical oncologist, so I'm going to concentrate more on systemic therapy options for squamous cell carcinoma, which is incurable by surgery or radiation. Historically, chemotherapy was used for a very long time. It was very toxic, lots of side effects. Nobody liked it. Then we made some advances, and EGFR-based targeted therapy came along, which was better tolerated and had better responses till finally about 5-7 years ago, we have seen the advent of immunotherapy in squamous cell carcinoma of the skin, which has really revolutionized the therapy of incurable cutaneous squamous cell. And literally, it has outdated chemo and EGFR-based therapies, and we hardly do that anymore. So a lot of the talk that we are going to talk about is going to look at immunotherapy and how it has enabled us to treat this aggressive cutaneous squamous cells in a more efficient and manner. Now, I'm sure that all of us here must have heard about cemiplimab. This is a PD-1 blocker, which is approved currently for the use of for treatment of patients with incurable cutaneous squamous cell. Just a brief outline of how it works. So we have tumor cells and T cells. T cells are immune cells which help us to remove tumor cells from our body. They have these targets called PD-1 on the T cells and PD-L1 on the tumor cells. And when these interact, there is a chain reaction which neutralizes the T cells and makes them non-functional. The cemiplimab is a monoclonal antibody. It binds to PD-1, which is present on the T cell, and interrupts this interaction of PD-L1 and PD-1, and that keeps the T cells active and reactivates their anti-tumor responses. So one of the first studies that came out looking at PD-1 blockade was through Dr. Migden and his team, who looked at the role of PD-1 blockade with cemiplimab in advanced cutaneous squamous cell carcinoma. It was a fairly large study for cutaneous squamous cell. It was done in 2 phases, involving about 26 patients in the phase 1 part and 59 patients in phase 2. All of these patients had previously been treated and had no really good treatment options for them. If you look at it, about 30% patients in the first cohort and 76% patients in the in the second cohort had metastatic disease. So these are basically advanced disease patients with a lot of disease burden and had failed in conventional therapy. And the results were truly, eye-opening. This looks at the plot of responses in these patients. And you see, these are the patients who have responded, with blue showing stable disease and the purple ones showing complete and partial responses. And the response rate was very, very high, very encouraging. And what we saw was that at least 50% of patients in the first phase and 41% of patients in the second phase had partial response, which means that the tumor shrunk. Some of them also had a complete response, which means the tumor was not visible anymore. Only about 12% patients in the first cohort and 19% patients in the second cohort had progression. So the overall disease control rate was in the range of about 80%, which was very, very high for any squamous cell cancer, cutaneous squamous cell study. This was followed with an updated analysis of their data, which again showed that the responses were very, very durable. Long-term patients who get this treatment were able to maintain their response to treatment for a long time. And this is, again, this study is also something that came out immediately after that, which showed real-world data of responses to immunotherapy in cutaneous squamous cell. Again, what we see here is that patients who are younger are going to do better, while older folks are going to do a little bit worse. Another startling thing in this study also is that when we treat patients who are immune suppressed or immune competent, their survival with immune therapy is almost the same. So that this study actually opened our eyes that we could treat patients who are immunocompromised also with cemiplimab. And so that study basically made cemiplimab the standard of care for patients with locally advanced incurable cutaneous squamous cell carcinoma. So again, the next step was how do we help the patients who have large tumors which are still resectable? And so the concept of neoadjuvant cemiplimab was used. There was this big trial by Dr. Gross, and they looked at stage 2 and to stage 4 cutaneous squamous cell, which were not metastatic, who were still surgical candidates, and to treat them with cemiplimab. And they had about 79 patients, out of which 46% has stage 4 disease, 48% has stage 3 disease. They all got 3 cycles of cemiplimab 3 weeks apart, and then they were evaluated for surgical resection. And again, the responses were outstanding. We saw that on pathology after surgery, about 51% of patients had pathological complete response, which means that they did not have any tumor left. And then they also had another criteria, which was called the pathological major response, which means that less than 10% tumors left behind, and another 13% patients fell in that category. So, which basically showed us that about 65 to 70% of patients had a great response to treatment, and some of these candidates could avoid adjuvant therapy like radiation. And looking at the adverse event profile, it was very well tolerated with 3 doses. Hardly any significant side effects was seen in these patients. So currently, neoadjuvant therapy with cemiplimab has become a big new trend and emerging standard of care for patients with advanced disease who are surgical candidates, but whose surgery is expected to be very difficult or have a lot of morbidity. And we also have multiple clinical trials here at Duke where we are looking at different combinations as neoadjuvant for these patients to help them help the surgery become less challenging. Another area where we see a lot of cutaneous squamous cell is the immunocompromised patients, and this is a very rough idea which tells us that as patients, this looked at solid organ transplant patients. As I told you earlier, Duke is a big center for organ transplant. We have a lot of patients who have had kidney transplants, and we can see over time these patients are, due to their chronic immune suppression, they have a 65 to 250-fold increase in squamous cell carcinoma. And these squamous cell carcinomas in these solid organ transplant patients are the most aggressive types, and they are going to be found in areas such as the head and neck, where surgeries are very, very morbid. And again, whenever we use cemiplimab, we also have a very high concern for organ rejection in these patients, and which can it's by itself be life-threatening. So these are immune-compromised patients, very challenging to treat, and there's a lot of concern for toxicity and organ rejection. But we have some encouraging data which came out of Dana-Farber last year by my colleague, Dr. Hanna, and his team. And so what they did was they took about 12 renal transplant patients who had metastatic advanced cutaneous SCC. They were given cemiplimab once every 21 days, and their immune suppression was changed to sirolimus, and they had a special dose of steroid regimen to help maintain their immune suppression. And what we found was a very, very small study, but the results were very encouraging. They were able to show a 46% response rate with tumor shrinkage in these patients. And the best part was that these patients had zero graft rejection. So they were able to protect the kidneys as well as bring about good responses with these patients. So as of today, when most of the patients that I see who have immune compromise due to organ transplant and have these aggressive cutaneous SCCs, the contract study regimen is what we are using, and our data itself shows that these responses are also going to be seen in the real world. Now going to the next step. So again, what are the next steps that are having or what are being done in cutaneous squamous cell? So we are looking at a lot of biomarkers to see how we can make these therapeutic options better. We are looking at things like circulating tumor DNA and the tumor microenvironment to see which patients are going to respond better to immunotherapy and who are not. We're also looking at omics technology like genomics, improvement in clinical pathological features, and again, also newer drugs and newer drug delivery mechanisms are being looked into. So the future is very, very encouraging for cutaneous squamous cell carcinoma. This gives us a list of some of the most important clinical trials that are going on with using immunotherapy in various settings. Some of them are high risk, some of them are for advanced disease. We also have a lot of new adjuvant studies using different combinations. So as a cutaneous squamous cell medical oncologist, I'm very, very happy, and we are very optimistic that we are going to be able to get more and improved and better treatment options for our patients. So with that, I think I am almost at time, so I'm going to conclude, and I will let Dr. Beasley take over. Thank you so much. We'll have questions at the end.
Excellent. Thanks for that great review. And it's really encouraging, that the transplant patients, especially have options now. That's been very difficult to treat. Thank you. I believe that Dr. Catterpall is next, so I'm going to have her load up her slides. And again, everyone, please feel free to put questions in now, although we'll do it at the end. Anytime you want to put a question in, it'd be nice so that we're ready to go when we get to that part. Thank you.
Hi, everyone. Hopefully it's been a smooth transition and everyone can see my screen and hear me okay.
Yes.
Yes.
Thank you. Well, thanks so much again for having me, and I really appreciate the AIM team for putting this together for our skin cancer patients. Obviously, we are very passionate about these conditions, and unfortunately, there is a lot of skin cancer, as Dr. Musavar mentioned, sort of in the Sun Belt. So my part of this talk will talk about a basal cell carcinoma. This picture is actually a real basal cell carcinoma. Obviously, it doesn't look like this to naked eye. But when we look at it through this device called the dermatoscope, you can see all the blood vessels that the tumor is sort of summoning to the skin to, help get the nutrients to grow. Often, there's some erosions like this in the tumor, so it can often be kind of bleeding, and there's a lot of scarring that it causes. So basal cell skin cancer being the most common type of skin cancer, not quite as aggressive as some of the others, but just certainly a big nuisance with its blood vessels and bleeding and pain and things of that nature. So most common diagnosed malignancy in the U.S., I would actually go as far as saying, several other countries, South Africa, Australia, it is just out of all the skin cancers tends to be the most common. We estimate about 5.4 million cases, and also not just, only in Caucasian skin, but, several sort of, we call them like Fitzpatrick 3 and 4 sort of medium skin tones can get this as well as darker skin types. So it's something that, sometimes I feel it's if you're super fair skinned and, spend some time as a child in the sun, it's not a matter of, if you would get this, it's a matter of when. And we believe a lot of the sun damage happens before the age of 18. So for a lot of us, I wouldn't say the ship has sailed, but a lot of the mutations that lead to these skin cancers happen early on. So we definitely need to be careful about all things we talked about, tanning beds and things, not to add to that sun damage. But I think it's important to understand what this means and how to take care of yourself or your loved ones if you did get one of these tumors. And so even though it's a super common tumor, as you can see, it's a super rare disease to get metastatic, which means spreading to other organs and causing havoc. It does happen. Unfortunately, we do see this at Duke being a referral center. And so we'll talk a little bit about that in this talk, but majority of the cases, fortunately are early. So Dr. Muzaffar mentioned a little bit about the squamous cell skin cancer that's kind of listed out here. This is just a sort of a three-dimensional schema of the skin. So squamous cell skin cancers kind of start at the surface, I would say sort of these spiny looking cells in the middle. And so they go through like this pre-malignant to malignant sort of transition. Basal cell skin cancers start sort of at the base. They're the cells sort of at the bottom of the first layer of the skin. And so when they start to become a tumor, they certainly push up, but they automatically are invasive right from the get-go. Even so, though it's invasive right from the get-go, it's not as aggressive as a squamous cell skin cancer. And the reason for that is that basal cell skin cancers, they need to sort of grow in a mucinous kind of snot-like stroma. So it can't be quite as, it doesn't have quite the roots as you can see in the squamous cell and melanoma, which tend to have these roots and invasive quality. So good for us as dermatologists that usually when we see it, it's usually sort of a small little pearly, almost like a pimple that's not going away, kind of shiny bump. Earlier stages can look a little bit even more subtle, just like a little red, flaky area. But this is the most common stage at which we diagnose it, kind of like a nodule, like a nodular basal cell. And then when we look at it through dermoscopy, we see very clear features. So it's actually almost instantaneous diagnosis. So fortunately, we can often diagnose it early, but sometimes when it's on locations like, for example, the scalp, or especially the vertex where, as we age, our hair thins and may not be paying attention, it can turn into these ulcerated sort of nodules. And so, we'll kind of go through treatments for all sorts of stages. So just as a quick, staging, people always want to know, what is my stage? In basal cells, we're never saying, oh, this is a death sentence. But when do you get kind of worried a little bit more about it? And the answer is that if you don't take away anything else from this slide, it's mostly the size. So if the tumor is less than 2 centimeters, generally speaking, it's usually well-defined, and it's like the first time this tumor has come up on the skin, it's generally pretty low risk and tends to be very easy to cut out and remove. But for tumors that become bigger than 2 centimeters, and I would say bigger than a centimeter in special locations, like, for example, near the eye or on the lip, or on the ears or nose, then they tend to become a little bit more challenging, both from a surgical standpoint and also have a higher chance of coming back or become recurrent. And then when we look at it under the microscope, they can have a more aggressive histology, all these sort of big words that our pathologists help us determine. So when they're more aggressive, sometimes we have to use other treatments besides surgery, like add some radiation or some other treatments. Some other things, so we fortunately have some data on, if they are bigger than 2 centimeters, what are sort of the risk of that tumor coming back after surgery, which is surgery usually the first line treatment for basal cells, because we can just cut out that whole nodule and cure it. And the idea is that, there's basically two things that we worry about in basal cells if they're bigger than 2 centimeters. One, is it going to come back after we cut it out? And the other is that, is it going to spread to, local lymph nodes and lead to any kind of death? So the spread and the death are sort of combined here. So death is very rare. So mostly we're looking at the spread. And, the head and neck location by far is just the most dangerous to have a large tumor. And the reason is because lifelong we're getting sun exposure in this area, and basal cell is a disease of chronic sun exposure. So, I kind of think about the amount of sun exposure everybody is allowed to have before they develop cancer as like a bucket that's given to you. And everyone's bucket is a little bit different. You know, the lighter fair-skinned you are, more family history of skin cancer, you have your bucket smaller, so it's going to start spilling sooner. So the folks that are fair-skinned and have a family history tend to need to be a little bit more careful about adding to that, adding more sunlight and sun damage to that bucket, and vice versa. So head and neck, definitely a very challenging location. If it's a big tumor where it's invading not just the first, the second, but into the third layer of the skin, which is fat, you know, chances of spread are definitely, chances of recurrence are definitely higher, 3 times. And then if you treat it with Mohs, especially on the head and neck, tends to be that the recurrence is less. And that's why a lot of times when people say, well, I have a basal cell on my arm, last time I had it on my nose, I did Mohs, but why are we not doing this on the arm? And that the reason is exactly this. When it's on the head and neck and we're not treating it with Mohs, reduces the risk of recurrence, basically. So that's why we try to do Mohs, especially for tumors that are larger than 2 centimeters. So in this study, Mohs showed recurrence risk decreased by 86%. So, and if anyone has had a skin cancer, hopefully they've come across some of these treatment options that were discussed. You know, so Mohs is one treatment, but if you have a small tumor or a tumor off the head and neck, we can do just a plain surgical excision in which we take a 4-millimeter margin. You know, there's something called local destruction procedure called an ED&C, where we just sort of curette the tumor. We don't do that generally on the head and neck, but we do that other parts of the body, and the cure rates are somewhere in the 98%. So that's a really easy, good way to not have stitches, and the infection risk is small. When it gets to be the 2-centimeter and deeper tumors where the recurrence risk starts to get high, then we start to think about radiation. And then there is this option to remain untreated. And I will just mention that because, you know, as we age, our risk of skin cancer goes up. So we definitely see more skin cancer when people turn, you know, in their 70s, in their 80s, and their 90s. And I personally have had several patients in their 90s just choose to remain untreated because the chances, as I said, of this metastasizing are very low. And so if you're dealing with multiple health problems and it's a tumor that's just there, not bleeding and not causing trouble, perfectly good option to just watch it. We call it like sort of this, you know, observation, active observation, and only remove it if it's becoming a nuisance. So I will say that that's a very important option to consider, you know, if you have a loved one who has a basal cell that's not causing them trouble and they're, you know, have other comorbidities. So just going to Mohs, one thing I just wanted to mention, you know, since this is something that a lot of people go through or at least have a loved one to go through, some of the tips and tricks, you know, that can help make this a little bit easier, you know, is just to read the instructions from the Mohs team when they're about to do that. And this also goes for surgical. And generally speaking, you don't have to stop many medications, including blood thinners, because if you're on a blood thinner, it's usually for a good reason. And we want to make sure that we don't cause a stroke or heart attack in the process of taking a small, you know, tumor. I do find that if it's not in the ear, if the tumor's not in the ear, bringing like some sort of music with you can be very soothing because there's a lot of, you know, noise and instruments clicking, and that can cause a lot of anxiety, especially the first time. And, you know, on a location like the face. Some of my patients also bring like essential oils with them and just sort of, you know, calms them. And especially if you're wearing the mask, you know, you can put a drop of it inside the mask. This also helps a lot when you're going through an ED&C procedure. The scrape and burn procedure can be very smelly because it smells like burning chicken feathers is what people tell me. So it can be really traumatic to be thinking that's your own skin burning, you know, so having an essential oil can be really helpful. And then Mohs, often the Mohs surgeons are, you know, commonly prescribed anti-anxiety medication just for the duration of the procedure, and that can kind of help with just calming down any nerves you may have. Preparing with wound care supplies. And so after the procedure, like for example, this gentleman, he has these stitches. I mean, it looks like he healed beautifully, but he's, you know, it was probably pretty swollen and painful because a nose is a very tight skin area. And after the surgery, the wound swells and the swelling is very painful in the skin. So having some sort of a pressure dressing supply kit can be really helpful if you have a loved one who's a medical professional, like a nurse or somebody, you know, just to kind of get their services, reserve them ahead of time and help them, you know, re-bandage your wounds. And then, you know, just know that the scars on the head and neck heal really well. A lot of people are really worried about what it's going to look like after they're done, but you can see it looks beautiful after just because of the great vascular supply we have in the head and neck. And then a lot of times post-surgical, like scar creams can be helpful, but we generally just good old-fashioned massage and Vaseline and sunscreen do the trick. But Mederma and some of the other ones are pretty good as well. So just getting back a little bit into sort of the data. So what if you have someone that has like a fairly advanced tumor and surgery and radiation are not an option? turns out that 80 to 85% of our basal cells have a single, have a particular type of mutation in one pathway. So they're genetically somewhat similar. So the good thing is we can actually kind of hit that mutation and stop these tumors from growing. And there's 2 medications that are FDA approved for this. And they show that the sort of disease control rate on these medications is almost 90%. So 90% of the patients that are on these patients tend to become no worse. And a lot of them, improve. And somewhere in the 60 to 70% of the tumors do shrink down. And then typically if the medicine works, it continues to work for several months, up to 2 years, depending on which one we're talking about. But eventually, unfortunately, there is some resistance if the tumor is not cured at that point. So therefore, these medications are not considered upfront. So a lot of times people will come and say, well, I've had so many basal cells removed, why can't we just do a pill? We can, it's just that your cure rate's not quite as high. But there is a room for that, because a lot of times we have people come in and they have just, 30 basal cells. And it's just impossible to start cutting every single one without causing very, very, very significant morbidity. So we do sometimes use these oral medications for that. There's some side effects with them that are listed here, the most common ones being sort of the muscle cramps that bother people, especially when you're living in the sun belt with a lot of heat, hair loss and taste disturbance also, affecting some quality of life. But for the right person, this could be a game changer. These medications can really reduce the morbidity. And most of the side effects do tend to be reversible, those medications, except for, I think, the hair loss, depending on how long you've been on the medication. And then coming back to the immunotherapy, which has become the catch-all for a lot of cancers, Libtayo or cemiplimab that you just heard about from Dr. Musaffar in squamous cell is also approved for basal cell treatment, both for a locally recurrent or a locally large tumor on the skin, and also for metastatic basal cell. And this was a phase 2 study with patients who had large tumors, aggressive tumors, or metastatic tumors. And then there's a condition called Gorlin syndrome where patients get hundreds and thousands of basal cells in their lifetime because of a genetic mutation. Unfortunately, in that population, this medication did not work quite as well. So if there's anyone here listening, Gorlin syndrome certainly would be try it, yes, but the response rates tend to be lower. And we think is because for Gorlin syndrome, the basal cells are not actually as mutated because they already have the one mutation, at birth. And so most of their tumors are not quite as aggressive. But it's given the same way, 350 milligrams, which is the same dose as the squamous cell every 3 weeks. And in this trial, basal cells were evaluated both with measurements of the scans and the photographs, for each 9-week cycle. And in this patient, again, with any trial with basal cell, you're going to see an older population, although the youngest patient was 38 years old. And I would probably bet that patient had Gorlin syndrome, to get an aggressive tumor at that age. So mostly, you tend to see these to be more aggressive as people get older, and also more common in men. I blame golf for that. I'm just kidding. But yes, tend to be men. Not sure why, but I think probably just because of the jobs and like the recreational activities. But we do think it's a majority sun-related tumor, mostly Caucasians. And 100% of the patients have previously taken a hedgehog inhibitor. So cemiplimab, as opposed to in squamous cell where it's like for aggressive tumor, it's first line. We generally first still treat people with the oral medications that we were talking about, the Eravig and Odamzo, before we go on to the Libtayo. And I'll talk about why in just a second. But again, head and neck tumors being most commonly treated in this study. And so what was what happened basically? So we started to talk about, what are the outcomes of the study? So there's a lot of people that discontinued this study, and most common reason was progression of disease. And the progression of disease occurred in like 1/3 of patients that had the aggressive tumors, but not metastatic. So the metastatic people, tend to progress a little bit more. So the response rates in this study tended to be a little bit lower, and disease progressed a little bit. But you have to kind of remember too, these are more aggressive tumors that have failed surgery, failed radiation, and also possibly failed the oral medication. So these are the worst actors, that were on this study and usually treated with Libtayo. So something to think about, when you're thinking about immunotherapy, tends to work a little bit better in squamous cell than it tends to work in basal cell. The other reason not to start with Libtayo, at least in basal cell, like right off the bat, is just the side effects. So most of the common side effects are pretty easy to manage, although maybe not quite as easy for somebody to endure, and good for people to know if you have a loved one going through this. But 1 in 3 patients tended to get a serious reaction. So when you're dealing with the basal cell that may not be quite as serious, and you're dealing with serious reactions like, bad diarrhea, colitis, things like that, like bloody diarrhea, you kind of have to think about what are the pros and cons of this medication. Fatal adverse reactions, which is where people died while on Libtayo, not always of Libtayo, but we're getting this medication, is 1.5%. Now, that fatality is basically zero with every other treatment that we've discussed so far. And so that's another reason why we don't typically start with immunotherapy, although generally it is very well tolerated, and the death from Libtayo is much lower because we recognize the side effects much earlier and treat them much earlier. But it is something to think about when we're dealing with it in terms of basal cell skin cancer. So it worked clearly in the large tumors that hadn't metastasized. About response rate somewhere in the 30%. 1 in 3 is sort of what I take away from the study. But the people that had metastatic basal cells, it was about 1 in 5 patients had some skin shrinkage in their tumors. And again, these are aggressive tumors that have already been through all the other treatments. So we are grateful to have this, treatment for our patients. But just know that as we go past, as the disease continues to come back, it becomes harder and harder to treat. So in conclusion, if you did respond to Libtayo, let's say you were on those lucky people, 1/3 that got better, what happens? How do people feel about it? Most people said that they maintained or improved their symptoms, functioning, quality of life. So if unfortunately I cannot show you pictures from this trial, but if I could, you would see these large ulcerating tumors sort of shrink down to the point where at least they were not bleeding and painful. And so that's kind of, it is, even though on the surface looks like a lot of side effects, in the right patient, that could be the right option. And we have, amazing medical oncologists, who can help you make that decision. So as far as like the aggressive basal cells, I've just listed some pros and cons, of all the 3 drugs that we have that shrink these. I think the bottom line is to know that even if you have an aggressive tumor, most of the tumors we treat very easily, but if you have an aggressive tumor, we've got some really good options where we can balance some pros and cons. And with that, I really thank you for your attention, and wear your sunscreen.
That's great. Thanks so much, Dr. Ketterpal. It's a good reminder for us all. Let me while I share some slides here.
You're going to go ahead, April. Great.
Oh, sorry, Georgia.
That's okay. I was going to say I'm giving up golf. And Dr. Slamvik is going to take it away now with Merkel cell. And then just as a reminder, we've got some questions coming in, and we're going to do all the questions at the end after Dr. Slama. So keep them coming, and great job so far.
Great. Thanks so much. So you'll hear some similar themes from what you heard today from Dr. Muzaffar and Dr. Ketterpal as we talk about a different type of skin cancer, Merkel cell carcinoma. These are my disclosures. So just a brief overview, we're going to go into a little bit of the basics of Merkel cell, just a little bit of the epidemiology and who it affects, how we do some of the initial management, how we integrate care with surgery and radiation oncology. And I am a medical oncologist, so my expertise is in giving drugs for more advanced stages of cancers. So we'll talk a lot about some of the advances in the newer immunotherapies, and you'll hear a lot of similar themes to what you've heard earlier with other types of skin cancer, and talk a little bit about some ongoing clinical trials that we hope will continue to improve outcomes for patients. So, the first question patients often ask me, of course, is, not only what is Merkel cell carcinoma, but what is a Merkel cell? And Merkel cells are actually a type of skin cell that live in the top layer of the skin, or the epidermis. It's believed because they were originally found near nerves, and it's now known that they're related to relaying touch or sensory information to the brain. They also produce certain hormones, but we don't really know all of their functions. But that's why you'll sometimes hear Merkel cell carcinoma referred to as a neuroendocrine carcinoma of the skin, or that a Merkel cell is a neuroendocrine cell. But but for today, we'll continue to call it Merkel cell. It is a rare, potentially aggressive skin cancer. I've showed a representative sample here of what it might look like, but it often occurs as a painless lump on the skin that can often grow rapidly over weeks to months. And then to the right, you'll see a picture of what a Merkel cell looks like under the microscope, and that's how our pathologists help us make that diagnosis. When we look a little bit about Merkel cell and who gets it, so I mentioned it's a rare cancer. There are about 2,500 to 3,000 cases a year in the United States. But you can see here on the left that the incidence is on the rise, and this sort of tracks things over the past sort of 40 to 50 years or so. And the risk factors for Merkel cell are very similar to maybe what you've heard earlier tonight from my colleagues. So certainly age, we know, is a risk factor. It's actually very, very rare for patients under 50 to get a Merkel cell. It is certainly associated with sun exposure, so sun-exposed parts of the body, like the head and neck, the trunk, the arms. It can be to some degree associated with a suppressed immune system, although the vast majority of patients with Merkel cell don't have any clear immune suppression. And I think all these factors really kind of have rolled into one, because if you think about it, we have an aging population, and certainly for patients who may be over 65 or 70, we didn't know as much as we know now about sun protection, that advice from Dr. Ketterpal. So we have increasing numbers of patients who there just wasn't a general public awareness and education, perhaps earlier on, stressing the importance of sun protection, that puts these patients at a relative increased risk, and similar features that you've heard earlier, but having lighter skin, fairer skin type, of course, also put people at risk. So just because I'll be talking about something called the Merkel cell polyoma virus a little bit later, I just wanted to show a little bit of science here and talk about how we think Merkel cell carcinoma is formed. When we talk about mutations or DNA damage from UV radiation, this is a little bit of a schematic of what we're talking about. So you can see on the left-hand column, this is a cell DNA, and that exposure to ultraviolet light can cause alterations in that DNA, which we believe can lead to a cancer like Merkel cell. On the other hand, we also know that in fact, the majority of Merkel cells appear to be associated with something called a Merkel cell polyoma virus, which similarly can integrate into the DNA and cause DNA alterations that can lead to Merkel cell. I'll talk a little bit more about this later, but this can sometimes play into how we keep track and follow up patients after they've been diagnosed, whether their cancer is found to be associated with the polyoma virus or not. And then I'm always really important, though, to kind of point out, because another question we get asked when we start talking about genes and mutations, these are all genes that are in the tumor and the cancer cell, or the cell in the patient's body. These are not genes that are inherited or passed on. So to the best of our knowledge, there's not really an inherited form of Merkel cell, that all of these appear to be really, spontaneous, kind of associated with the risk factors that I was describing earlier. So I'll do a brief overview of some of the initial management. And I think, the one theme I hope to highlight in my talk tonight, and I think, so lucky to be on with my colleagues who practice in a number of different specialties, because of the rarity of this cancer, again, contrasting with some other skin cancers, I really think, I'm biased, of course, but I really think evaluation at a center where surgeons and oncologists and radiation oncologists have Merkel cell expertise and partnership with dermatology. Again, because so much of what I'm talking about, again, it's impossible to give a defined treatment plan for any one patient. And so much of this really does depend on the specific clinical situation. Also a little bit different than many other skin cancers. Usually we get some type of imaging prior to proceeding with surgical excision, although every case varies a little bit. But because Merkel cell can be potentially aggressive, there's some patients where we note spread at the time of diagnosis, and that would change our treatment recommendation. So again, depending on the size and location, and again, just depending on the overall patient, imaging is something that is sometimes considered. The mainstay, like all other skin cancers we're talking about here, is often surgical excision. We haven't talked about it tonight, and certainly if there are questions about this procedure, Dr. Beasley will be available at the end, but talking about a sentinel lymph node biopsy is sometimes considered for patients. And I just provided a diagram of what that looks like. So that's where the surgeon actually at the time of surgery injects a radioactive substance with or without a blue dye into the tumor to detect the first draining lymph node. And they can detect that there, as you see, with a probe. And then they can remove those first draining lymph nodes. And that gives us a really good sense of whether the rest of the lymph nodes might be involved or not. And that's important as we think about the patient staging, which would have implications for additional treatment recommendations, such as radiation, again, which is decided as part of the team, as well as any additional therapy or trials that they might be eligible for after surgery. So when I started off, you heard me mention the Merkel cell polyoma virus, and I just wanted to give an example of how that can impact surveillance after surgery. So we think about half of all patients have antibodies to the polyoma virus who have been diagnosed with Merkel cell, that there's actually a test in the blood that we can send that out to a lab. And you can see here, there's reasonable data to suggest that that can help us with surveillance and give us a sense of the state of their disease. So typically what we do, we would check this blood test around the time of surgery, either right before surgery or maybe right after, where we would expect it to still be positive for about half of patients. And if it is positive, we can actually follow it over time with a blood test. And what we ideally want to see is what you see with these 3 patient examples below. Each time point, each dot on the line is a blood draw time point. And you can see nicely after surgery that their polyoma viral titers actually went down to 0 or at least decreased. And these were patients who had no evidence of recurrence. And, we still don't know the perfect way to integrate this, but for some patients, for example, if they have a falling titer that stays negative, that might mean they need less frequent imaging studies, which, can be time consuming or add extra expense. And again, this is really something to discuss with your multidisciplinary care team. On the other hand, if we see after surgery, a patient really their titer doesn't go down all that much or starts to rise, even if scans are clear. Again, there's no perfect test, but that may also impact how we follow patients. So I can say that in my clinic, if we started seeing titers go down and then all of a sudden started seeing them go up again, we might bring that patient back in for more frequent or more intensive surveillance. But again, I think because this is a rare cancer and because each situation is unique, we're still really learning the best ways to integrate all of the new technologies that we have. This, I just wanted to show here as a reference as we talk about sort of staging and prognosis for Merkel cell. I will draw your attention to the date. This does not include the prognosis with some of the newer therapies that I'm going to talk about. But like many other cancers, we use staging to help us gauge prognosis, which then helps us gauge risk and benefit of various treatment approaches, because certainly if patients are highly likely to be cured by surgery alone, we don't really want to expose those patients to any extra risk or extra treatments. But for patients who have maybe a more advanced stage or poor prognosis, that's a time where it maybe makes sense to start thinking about some additional treatment options. And so we can see that, even for localized or early stage Merkel cell, you do have a number of patients that have a recurrence of their cancer, but certainly that increases with stage. And historically, going to be glad to talk about their differences now, of course, but historically, the prognosis for patients who couldn't have surgery or complete removal of their Merkel cell was actually quite poor. So you've already heard about this tonight, and it's a theme, and I think that's because it's really hard to overstate how much immunotherapy has really completely changed the landscape for so many cancers. So not just skin cancer, but many other types of cancer as well. But in Merkel cell, I would say it's shown particular promise. So this is just a diagram, again, to kind of review how these therapies work. But you can see here that normally a T cell might be quiet. You want your T cells, which are your main sort of immune cells, your kind of the cells that are involved in fighting infections, but also the cells that are involved in hopefully targeting things like cancer. And normally they need a couple of different signals to tell them to turn on. So they need to recognize something as being foreign, which theoretically you can see here would be a cancer cell, but they also need additional gas pedals, if you will, to kind of help them do their job. And what cancer cells really do is they kind of hijack the body's own normal protective mechanisms. And cancer cells have found a way to put a brake on our T cells. And you can see that it essentially puts that T cell to sleep. So the T cell really can't do its job anymore. And what's been so revolutionary about checkpoint inhibitors, this class of medications that we've all been talking about, is they really block that brake. And you can see that they then remove that brake and allow the T cell to become activated again and do the job that it was intended to do. So with that in mind, so I'll talk about pembrolizumab, which you've heard some about. So a PD-1 checkpoint inhibitor, and this is in patients with advanced Merkel cell carcinoma. So this was a study in about 50 patients who were all had not received prior treatment for their Merkel cell. And here you can see pretty dramatic benefit. This is something we call a waterfall plot. Which basically each line is a patient. It didn't really seem to matter in this trial. The blue and the red is if the patients were virus positive versus virus negative. Each group of patients appeared to have benefit. But here what you can see is that the majority of patients clearly had benefit and shrinkage of their tumor. So that 0 bar is sort of their baseline. So when we see the waterfall going down, that means the tumors are shrinking. And when we see the waterfall kind of rising up there on that left-hand tail, that means the tumors were growing. And this, as an oncologist, is definitely the kind of waterfall plot you want to see. You want to see that the majority of patients are having tumor shrinkage. And in fact, a lot of patients are having quite a bit of tumor shrinkage. So those bars on the far right that go all the way down, that means those patients had complete disappearance of their cancer on imaging. So that's a first important feature. So PD-1 therapy results in high response rates, so high rates of shrinkage. But the next thing that we really think about is, well, how long does that last? Because it's great to shrink the tumors, but what we really want is we want that shrinkage to last. Ideally, we want it to be permanent. And so these types of graphs give us that kind of view. And so on the left, this is what's called a spider plot. And what I like to say is you really want this kind of plot to sort of all kind of trend downward, really look like an open umbrella, like a lopsided open umbrella, where lots of tumors are shrinking and then it's kind of continuing for a very long time. And you get that sense here because that the bottom x-axis is appears the responses are going on for months. And then you can see that in the right-hand column, or the right-hand graph, that this is the median duration of response that you can see for those patients who had a response to pembrolizumab, the median duration was not reached. So what that is telling us is that the majority of patients who get that initial shrinkage tend to maintain that shrinkage. And that's exactly what we hope to see with immunotherapy and results in long-term benefits for our patients. So just to give a sort of historic comparison, this is what we used to think as sort of the standard in Merkel cell. We used to give chemotherapy for this disease, and the median survival was about 9 months. And again, translated with pembrolizumab, you see median overall survival was not reached again with many months of follow-up. So again, that hope that patients do well, the patients who do well initially continue to do well for a long time. Just to be complete, I did want to mention another PD-1 pathway drug. This is a PD-L1 pathway drug called avelumab, which is also approved for Merkel cell. And I think this is important because it just highlights, and these were patients who had had previous treatment. In this case, it was largely chemotherapy. And the graph on the left overlays the curve of the avelumab arm. So you can see this tail of the curve. So while not everyone benefited, those that did appeared to do well. And these curves are historic chemotherapy trials. So you can see that the vast majority of patients, unfortunately, did not benefit long-term from treatment. And again, we saw similar benefit in terms of overall survival, that even with patients with prior therapy, which we often think can sometimes be harder to treat, the more lines of therapy a patient has received, the harder it is, the more work sort of the next line of therapy has to do. But again, even in previously treated Merkel cell, we saw that benefit. This is a swimmer plot, and again, it just really confirms what we saw in the first-line patient. Each one of these are an individual patient, and you can see that the triangles and the green squares are patients when they had a response. You can sometimes see it takes a while to get that response. So sometimes we don't see that full response until several months after immunotherapy, which is a little bit different than other types of therapy. But you can see the majority of patients who initially benefited were maintaining that response. But certainly at the bottom here, not everyone. There were some patients who had some initial benefit and then things started to grow again. This has already been mentioned, and I think Dr. Catterpall did a nice job of reviewing side effects. Certainly, it is always a risk-benefit discussion for our patients because, I've talked about all of the great benefits of immunotherapy, but we know immunotherapy can certainly have serious side effects, which is why we want to be cautious of when we use it and use it in the right situation for the right patient. So kind of switching gears to the next phase, we've said all these great things about anti-PD-1 therapy, which is really now the standard frontline treatment for Merkel cell. But if we are glass half empty, we acknowledge that still means about half of patients aren't benefiting from that first line therapy. And so one of the strategies has been, in addition to taking one break off of the immune system, to take a second break off with a drug called ipilimumab. This was a phase 2 trial that did include 2 different groups of patients. And the take-home point here was that the addition of radiation did not really add any additional benefit to the immunotherapy here. But it did show us that this 2-drug combination or dual checkpoint inhibition could sort of rescue some patients who had a prior growth on prior immunotherapy. So when we see that, we often ask the question, well, if it works in the second line, let's try it as frontline therapy. Maybe 2 is better than 1, which has actually been the case in some other skin cancers. And the take-home point here is that that was really not the case. You can see Nivo, which is another PD-1 drug, had a very high response rate for the frontline setting. And very similar to Ipi-Nivo. And so, while this trial, I think, was interesting, it really set home the point that it doesn't take two drugs in the first line setting, and we know that the toxicity is much higher with the 2-drug combination, and so that's why still for Merkel cell, the standard therapy is just one drug. I'll talk a little bit about here. Dr. Musavar already talked about neoadjuvant therapy, but the thought, if we give some immunotherapy before surgery, maybe we could do a better job of stimulating the immune system with the tumor still in place. So it gives more T cells that can kind of increase that chance of an immune response. And this has also been done in Merkel cell. So this was a small trial done for patients with resectable Merkel cell. They got 2 doses of immunotherapy prior to surgery. You can see this patient here had several large lymph nodes under their arm. And this is what it looked like after those 2 doses. You can see pretty dramatic shrinkage, and similar benefit was seen across the group. So this was, again, a waterfall plot of individual patients on that trial who had tumor shrinkage. And importantly, I'll draw your attention to what we call the pathologic complete response and the major pathologic response, that more than half of patients either had no tumor present, in pathology at the time of surgery, or only about 10% tumor that was still alive. And so that's really considered a really good prognostic sign for these patients. And you can see that that correlates here. So for patients who have a complete pathologic response, it gives us an early signal that they're going to do really well. Looking forward to the future. This is a trial that we had open at Duke, where, again, trying to look at, for those higher risk patients after surgery, does giving some additional immune therapy after surgery further reduce the risk of cancer recurrence? We don't actually know the answer to this yet. We hope to have results of this trial soon. But again, an example of how immunotherapy has been being integrated earlier and earlier in the management of Merkel cell. So this is just our summary. Certainly a rare skin cancer that certainly does have the potential to be aggressive, which is why we feel at Duke that seeking an opinion with an expert, seeking that multidisciplinary opinion is really important. And while certainly I'm really encouraged at all of the progress that's been made, I think still there's a lot of room to go for our patients. And this is where clinical trials, I think, can be so valuable. Thank you.
Excellent. That was really cool. A lot of good questions are kind of rolling in. I think before we get to the question answers, we're going to hear from Ann Taylor about some resources for Maine.
That's right. Thank you, Dr. Beasley. I appreciate it. I want to be sure and thank you for serving as our moderator tonight. We're so excited to co-host tonight's symposium with Duke University, and I want to thank our panelists for their collective wisdom. I just want a minute or two to talk with our viewers about AIM at Melanoma's new website, AIM at Skin Cancer. We launched that back in January. For many years, we have had a website that offered educational information to individuals that were diagnosed with melanoma. And now we have a website that specializes in offering similar information for individuals that are diagnosed with Merkel cell and basal cell and squamous carcinomas. Already, our website hits are primarily on the pages that center around staging and treatment and side effect information. We understand why newly diagnosed patients are going first to those pages, but I want to tell you about some other information that's on our website that we want to be sure and direct your attention to. The first one is a section on caregiving. We know that caregivers are oftentimes very instrumental in helping to make decisions around treatment care. And so we want to give some advice to caregivers about how to support their loved one during treatment. Secondly, we have a service called Ask a Skin Cancer Nurse. Krista Rubin is an oncology PA who's been working in this field for over 30 years. This is a free and confidential service. It is not to change your plan of care, but rather to make sure that you understand the treatment options that your care team are offering to you. And finally, I want to make sure that you know that we have our ever-growing media library. Krista, for instance, is making a number of webinars based on the questions that are coming to her from the public. Some people learn by listening and some by reading. And she has done some fantastic webinars for us based upon those questions. And then we have 6 symposiums a year that we're putting on through AIM at Skin Cancer. This one, for instance, will be taken and edited. The presentations will be edited and divided by topic and then put back into our media library so that members of the public can access them again and again. So if you have any questions, if I can guide you to something on either of our websites, please contact me. I'm going to put my email address into the chat. And with that, I'm going to hand the baton back to Dr. Beasley for our Q&A session. Thank you.
Excellent. Thank you. I took care of I answered a few straightforward questions in the chat. And so we're going to start back with Dr. Musafar. How are you? So this patient asks, I have rheumatoid arthritis and received immune therapy already. I was just diagnosed with squamous cell cancer. What do I do? Do I have to switch immunotherapy drugs? So I think she's referring to being on rheumatoid arthritis and immune suppression and how we deal with that.
Right. Again, that's a very important question, and that's a very important patient population that we see. Patients who have some kind of an autoimmune diagnosis like rheumatoid or SLE, scleroderma, and they are here seeing us for a squamous cell skin cancer. And again, those patients are on immunosuppressive drugs. And we see historically in small studies that if we do immunotherapy for these patients who have something like rheumatoid arthritis, there is at least a 30 to 50% chance that the disease may flare up. So again, whenever we have these patients in our clinic, we're going to look at the whole picture of how severe their skin disease is, how severe their rheumatoid arthritis is, and make an informed decision. Sometimes our hands are tied in our ability to use immune therapy for these patients. And in those cases, we do alternative options like EGFR blockers. So again, very complex situation, and the whole thing has to be taken into account so that we can make a decision.
Yeah, those are challenging cases. Dr. Catterpole, I'm going to switch over to you. I'm going to try to fit both of these questions in if I can. So it sounds like basal cell is very treatable, but does this mean that I am now at greater risk for other skin cancers? So that's one. Then I'm going to ask you to remember that. And then the second one is, how frequently should basal cell with the biopsy positive be followed if you're going to just kind of watch it, like if the patient wants to watch it? So one, what's your kind of risk once you get a basal cell? And two, how often should it be followed if you're going to try the observation?
Yeah, both great questions. Probably should have addressed those in the talk. So thanks for catching. I think there are several studies that show once you have a basal cell, you have an increased incidence of future basal cells in the first 2 years at the very minimum. So we generally screen people every 6 months for that reason. And I think there's also an increased association with melanoma. And I think, I'm not exactly sure why basal cell melanoma tends to go together, but it's an interesting thing. I mean, you would think basal and squamous, since they're both chronic disease, would show an increased, correlation as well. But the bottom line is, when you have a basal cell, we're following every 6 months with full skin tracks and looking for all 3 kinds of skin cancers. So at least for 2 years, and if there's no other skin cancer that we find, which thankfully does happen in a lot of cases, then we just end up following once a year, and for 5 years. And then the second question, was if you do have a basal cell that you want sort of to actively just observe and not treat, then we could, it depends. I mean, generally we're doing that in, folks that are elderly. So I usually tell them once a year, we want to take a look at it. But if in the interim of the tumor becomes bleeding or is painful, then, they can come in.
Yeah, excellent. I'm going to go over to Dr. Salama now. I'm also going to kind of try to work into questions sort of related to Merkel cell. One has to do with, is there's a bump that they thought was a wart. Is there any connection between the virus, because both the questions are kind of related to the virus that you talked about that causes either warts and skin cancer? So I guess they're asking if polyomavirus kind of also cause warts. The second question also has to do with polyomavirus, that should a virus negative Merkel cell be expected to respond better to immune therapy given their high tumor mutational burden? So advanced question there. But so does the virus, what else might the virus cause? I guess that's the idea of the question. And then virus negative Merkel cell patient and their responses to immune therapy.
Yeah. I'll try to attempt the first one. To the best of my knowledge, common skin warts do not have an association with things like Merkel cell or other cancers, skin cancers. But I will say I might have to rely on Dr. Catterpall to verify that. Yeah, I can certainly speak to the second part of that in terms of virus, polyomavirus positive versus negative. It's a common virus, and then obviously in Merkel cell. So I should say the vast majority of people with this virus don't get Merkel cell, but in the Merkel cell patients, the challenge with immunotherapy is that we really don't have a great predictive biomarker. Part of this may be because some of these studies are, on the smaller side when we're talking about the Merkel cell trials I presented. They may have 50 patients, 30 patients. That can sometimes be hard to detect a difference then between two groups. But at least, to the best of our ability, even looking at TMB, irrespective of the viral status, looking at other biomarkers like PD-L1, so expressing that checkpoint, that break, maybe there's a trend towards maybe an increase in benefit there. But I think the challenge with all of these biomarkers is it's been really hard, to get a read on them across, a number of cancers. This is true in melanoma as well. And I think we don't fully understand the cutoffs for what is, as I said, an advanced question, but what is TMB high versus low? It's probably unique to each cancer type. It's very dynamic. It's not like a gene marker that's inherent. The immune system changes, and there's, I think, a lot of work to be done on standardizing sort of when we check this. So I think I agree mechanistically it makes sense. We would think things with higher PD-L1 expression, higher tumor burden, to be more predictive, but it just hasn't, really played out. And importantly, we can't use it to select patients, to not give therapy, right? We know the therapy, we know the benefit is seen in patients irrespective of their TMB and irrespective of their viral markers. So we're just not at the point that we can use it to select yet.
That's a great answer. I guess Meena or Dr. Catterpall, I'll ask you real quick, and then I'm going to go back to Dr. Mustafar about, you're not aware that polyomavirus also causes other types of warts or anything like that, as far as you know. I think that's the heart of the question.
Yeah, so not the polyomavirus, but I do think like human papillomavirus, we think, which is, I would say like kind of the same concept, so HPV typically causes warts, but it can be implicated in certain squamous cell carcinomas. And so since we're on this topic, again, immunosuppression can lead these viruses to somehow, cause almost like oncogenesis. So, squamous cell cancer, particularly in transplant population, and I suppose other immunosuppressed population like rheumatoid arthritis. So, all these immunosuppressive drugs, we see a little bit more in that case. On the other hand, the cool thing is that we also can use some of these viruses to fight cancer. And Dr. Beasley, maybe you should elaborate on this, but sometimes these viruses can be turned into weapons to be able to deliver drug to these skin cancers. So maybe I'll turn it back to you, or maybe you can elaborate on that.
Hey, that's not fair. Yeah, so I'll quickly answer that, and then we'll go back to some squamous cell. So yes, we have there is one FDA approved, so it's not experimental. So I tell patients something called oncolytic virus, and that's right now it's only approved in melanoma, but it is a herpes based virus, and what they've done is sort of re-engineer to insert some other things that sort of make your immune system more robust. So it's not just the virus; they have done some editing to add some things, and we simply inject the tumors directly with it. It doesn't work for everybody, a small percent, but many of the viruses and other type of immune agonists to inject are being developed. Right now, we just have the one. It's a nice idea to try to minimize, side effects. But I think for people with, very large or very tumors that are going to eventually spread to distant organs, it's kind of a tough ask. So oncolytic viruses are definitely out there and being used. We still have some progress to make. So I'm going to go back to Dr. Musafar. So I have a patient saying that their squamous cell is very painful. And they're just asking if you think the pain, if the tumor shrinks, does that usually improve the pain, and other things that we do to sometimes manage pain?
So, yeah, again, the improvement in the pain would primarily depend on the location of the tumor. But we do see that tumors in areas like head and neck, where they are, abutting or compressing on critical structures and nerves, they usually would have improvement in their pain with response to the immunotherapy. And usually all patients who have pain, we would have our palliative care team take care of them. Again, taking care of these complex advanced cancers is always the multidisciplinary approach. And we are always eager to engage our palliative care team early on to help patients manage some of these symptoms.
Yeah, sometimes I've certainly seen more of these squamous cells, cause a lot more infiltration and pain than sometimes some of the other tumors. So I've always kind of wondered about that. But certainly patients' pain definitely seems to get better when we get a tumor response. So this one is back to Dr. Ketterpal a bit, because it's sort of a precursor lesion, but this person wants to know what the newest treatment is for large areas of actinic keratosis.
Yes, huge bane of our existence. Very good question. The term that we use for that is field cancerization. So you're seeing, large areas of the scalp or face with, lots of sprinkled actinic keratosis. And I think most people say if you're getting frozen more than 10 actinics in any dermatology visit, we probably need to think about treating the whole area, because there's probably many actinics that we're not even seeing. So there's a lot of different treatments that are approved. One of the treatments that I personally love the most is a combination of a chemotherapy cream and a vitamin D ointment. So it's fluorouracil and calcipotriene. Combining those two makes the fluorouracil much more effective. So brings like sort of this treatment course down from 3 weeks down to 4 days. It does need to be applied twice a day. And that does help with that sort of field actinic damage. Do you have to have actinic keratosis to do this treatment? I don't think so. You can even do it preemptively if you'd like. And a lot of our patients do that if they have a lot of sun exposure history. The nice thing about the combination is that it would light up the areas that needed it and really not touch the normal skin quite as much. So in the 4-day treatment regimen, you would see the areas that are getting lit up. They were probably precancerous because they're absorbing the fluorouracil more abundantly than the normal cells. So that's a really good treatment. The reason why that's sort of my favorite is because this study was done prospectively, and then the patients were followed for 3 years to see if it actually reduced the risk of invasive squamous cell skin cancer in the area which was treated with this combination. That's the only combination that I know where they actually followed up patients to see if they actually got cancer, which is the whole point of getting rid of the precancer, and it significantly decreased risk of invasive squamous cell. So we use that a lot. I use that a ton in our immunocompromised patients to prevent getting these skin cancers to begin with, the squamous cell. There's some others as well. There's also photodynamic therapy, which has some cosmetic benefit also. So sometimes people prefer that. But a great thing to ask, your dermatology team about to really even prevent some of these downstream, cancers with morbidity.
Awesome. So speaking of prevention, I think I got to all the questions, but I had some just in case. So Dr. Musafar, have you, is there any data or whatever, about, for melanoma and Merkel, we use a lot of adjuvant therapy, so I'm just curious if you ever think we're going to move the needle to squamous, or I think I'll let you answer. I have my answer.
Right. So,
Yeah.
adjuvant therapy is a very important component of treating advanced cancers. And there are two things to this. One is that for a long time, adjuvant therapy was considered an important part of treatment. And there were tons and tons of trials to do adjuvant therapy, not about specifically in squamous cell, but in other cancers. But what we do know now is that neoadjuvant treatment approach is a better approach and gives us better long-term control as compared to adjuvant, where there are no neoantigens really to stimulate the T cells. So that's a big important thing to look at. But we do have a trial here at Duke right now where we are taking these advanced cancer patients, treating them with neoadjuvant therapy, surgery, and then adjuvant immunotherapy after that to see if we can decrease the rates of relapses. And this is for stage 3 and stage 4 M0 cancers. So the question is there. It's a very important question that needs to be answered, and we are doing our best to get patients enrolled onto our study to see what the answer lies. So that's an open question that we hope to answer pretty soon.
Okay, good. Yeah. I think sometimes I think of squamous cell as not necessarily having, it's more rare for it to have distant metastases. And obviously you see those patients because it does happen. But I always think about whether, we can sort of try to figure out which are the ones, just like in melanoma, but it, tends to happen more often, that we have to prevent those distant metastases. So I'm going to come back to Dr. Salama and just ask, so and Merkel cell is not melanoma, but we sort of almost treat it nearly the same with immune therapy and then the combinations. Do you think that most of the immunotherapy drug, now we have another immune therapy drug for melanoma, we have TIL therapy, which now we take T cells. Do you think most of those things are also just going to work in Merkel like they do in melanoma, or are there any differences that you think?
Yeah, it's a great question, because I would say both. I would put melanoma and Merkel cell as sort of like the fairy tale immune therapy cancers, right? Like we have great responses to single agent, durable responses, and appears to maybe, be some additive benefit, with dual checkpoints. I don't know. I think you're referring to like the LAG3 that we see, in melanoma, which is, very closely related to PD-L1 in terms of its function. Certainly the field is moving towards triplet, combinations and additional things. But I think there are some key differences in terms of the biology, of the tumors. For example, just thinking about Merkel cell is extremely radiosensitive, and actually melanoma is on the complete opposite end of that spectrum in terms of being relatively radio resistant. So I do think there are some sort of key differences. I think the other practical piece from a clinical standpoint, and I alluded to this a little bit, but our Merkel cell patients tend to be, much older, more frail, additional comorbidities that I anticipate would significantly limit our ability to give cell-based therapies, which have a lot of toxicity. So I don't really see Merkel cell moving in that approach, but it will be interesting if we could get to a little more personal, more of a personalized, approach for Merkel cell as well.
Awesome. Well, everyone that knows me knows I like to be on time. So we did it. I think we'll give, maybe we're a minute early. Maybe if anyone else has closing comments, or Anne, maybe I'll turn it back to you. Thank all the panelists, and AIM, we really appreciate being a part of this.
Yes, and thank you to everyone who joined us. Thank you so much to Duke University, and we'll wish everyone a good night.
Good evening, everybody. Take care. Thank you.
All right. Bye-bye.